caring for the elderly and frail with end-stage kidney disease. It is Professor Natarajan Gopalakrishnan. He is Member Secretary, Transplant Authority of Tamil Nadu, formerly Director, Institute of Nephrology, Madras Medical College, Chairman, Scientific Committee, Indian Society of Nephrology, and Global Burden of Disease Collaborator, Principal Collaborator. Thank you for coming, and we look forward to your talk. Thank you.
Very good afternoon. I bring along with me greetings from India and particularly Chennai, the capital of Tamil Nadu. This is the institution where I served as head of the Division of Nephrology for 14 years at the Madras Medical College. Fine. So the topic for today's discussion is taking care of the frail and elderly patients with end-stage kidney failure. So this is how I have organized the talk. A few minutes on the concept of frailty and how do we assess and get to know the severity of it, and brief description of pathophysiology and the risk factors for frailty, and what are the implications and consequences of frailty, and the final part will be management and interventions. Frailty, we all take it for granted that we have understood what frailty is all about, but unfortunately, actually, it is a much deeper term. Many times we confuse frailty as synonymous with senility. It is not so. But of course, as the age advances, the chances of a person becoming frail is more common, but they are not synonymous. You can have a young person with frailty and so on. So that's it, fine. So frailty is actually a multi-system syndrome. To put it in simple words, it is a state of accelerated and pathological aging. Simply what do we mean by frailty is, there is a diminution in the physiological reserve. So that makes a person vulnerable for adverse consequences when the person meets with a stressor, a physiological or pathological stressor. That's it. And the prevalence of frailty is pretty high in all stages of chronic kidney disease. These are the rough estimates. Actually, obviously, it cannot be a single number because, the many countries, there are not many centers who work on frailty. And this is all based on published literature. As you can see here, the prevalence of frailty is more in patients with end-stage kidney failure and dialysis. So this is the global snapshot on the prevalence of frailty. As I've said, there's a wide range of prevalence starting from 21% in Japan up to 80% in some centers of India. And again, of course, I have to admit that not all the centers have adopted the same instrument to measure and diagnose frailty. Within brackets, I have mentioned the tool, the methodology of assessment of frailty and so on. So there is a lot of heterogeneity in measuring and grading the severity of frailty as well. But one thing is sure, the prevalence of frailty is pretty high among ESRD patients. And chronic kidney disease and frailty, they enjoy a kind of a significant bidirectional associations, meaning there is increased prevalence of frailty in chronic kidney disease because by multiple mechanisms, chronic kidney disease contributes for frailty, and the vice versa. And the frailty results in accelerated progression of chronic kidney disease as well. So who are vulnerable to become frail among CKD patients? Old age, the female sex, and other comorbidities like diabetes and severe hypertension, peripheral vascular disease, and so on. The pathophysiology by itself is a big topic. There are multiple pathomechanisms. The most important being the inflammation. We all know CKD is a state of the microinflammation. As the CKD stage worsens, the inflammatory burden increases, which has got huge implications, starting from the diminution in physical reserve up to accelerated atherosclerosis and so on. CKD is nothing but inflammation. So that tells upon the frailty as well. And similarly, oxidative stress, which is also another hallmark of the CKD that also contributes for it. And of course, CKD, there is anemia. Anemia contributes for multiple organ dysfunction, including cognition and cerebral function that contributes for frailty. Extensive vascular calcification and bone demineralization, and the malnutrition, which again is a consequence of multiple factors, including inflammation and oxidative stress. And of course, CKD, we all know it is a polyendocrinopathy. You name any endocrine organ, it is perturbed because of CKD, and each one of them will be contributing for multiple morbidities as well as frailty. Particularly, there are catabolic hormones like cortisol and parathormone. On the other hand, there is diminution of anabolic hormones like somatomedin and insulin and growth hormone and so on. So there's multiple mechanisms by which frailty becomes a prominent phenomenon in CKD. I'm just rushing up because the topic is management rather than the pathophysiology. Fine. And again, these slides talks about the multiple factors involved and the consequences of frailty in CKD. These two terminologies really attracted me when I was preparing for this talk. One is inflammaging. It's a kind of a new term, like, you know, the aging and the inflammation. The accelerated aging process and inflammation. This contributes to frailty in CKD. And again, immunosenescence. There is senescence of all the cells, including the cells contributing for immune system. So these two phenomena, they make a person, a frail old person with CKD, for adverse consequences, the vulnerability for multiple complications, poor health outcomes, reduced longevity, and so on. I would like to highlight certain aspects of it. The sarcopenia, which we often ignore in our patients with end-stage kidney failure patients. The sarcopenia is the diminution in the muscle quantum as well as the muscle physiology. The prevalence increases with worsening kidney function. According to some reports, the prevalence is as high as 40% among HD patients, sarcopenia. How are we interested in this topic? Frailty contributes for sarcopenia, and sarcopenia worsens frailty. What happens in CKD patients is that there is muscle fiber loss, which is replaced with collagen accumulation that results in stiffness of the muscles and which leads on to mobility impairment. And there are three principal mediators of CKD-associated sarcopenia. The one is reduced expression of myostatin, imbalance in ubiquitin proteasome system. We all know this is a kind of a scavenger system in each cell, right? Every cell there is a lot of accumulation of a lot of end products of day-to-day metabolism, and all these debris have to be cleared off. This is what is done by this ubiquitin proteasome system. That is not happening. So the accumulation of the waste, toxic substances of metabolism within each cell, that results in a diminished longevity and functionality of the cell. That happens in skeletal muscle particularly, okay? And there is a newer concept called sarcopenic obesity. You all might have heard about obesity paradox, meaning a person with CKD who's obese lives longer compared to a person who's lean. So this is obesity paradox. But the longevity is increased by obesity, but the sarcopenia and frailty is increased by obesity, because obesity per se can lead on to sarcopenia. How is it happening? There is myosteatosis, meaning the fat accumulation within the skeletal muscle that leads on to a lot of problems. Now we know the fat cell is not an inert cell. That can be a source of multiple pro-inflammatory cytokines that can tell upon the dysfunction of many organ systems and cellular systems. There is altered proteostasis and decrease in the number of motor units. There is mitochondrial dysfunction in the skeletal muscle, and so on. So this sarcopenic obesity is a newer concept. Fine. And again, there is a CKD MBD in patients with end-stage kidney failure. It can contribute for frailty in a very significant way. We all know hyperphosphatemia. Phosphate itself is a toxic to multiple cells, including the endothelial cells. It can cause transformation of the epithelial cells and endothelial cells into osteoblast-like cells, and that can lead on to trapping of calcium and so on. And that contributes to our vascular poor health and contributing for organ dysfunction and frailty. And when we advise our patients to restrict phosphorus, indirectly we are restricting protein that leads on to protein malnutrition. And we know when the phosphorus increases, the phosphatonin, the FGF23 increases. FGF23 per se contributes for low muscle strength. And because of the bone pain, there is reduced mobility, worsening frailty, and hyperparathyroidism being a catabolic hormone that can contribute for malnutrition. Fine. So now we have fairly understood that frailty is a significant problem in CKD patients, particularly end-stage kidney failure patients. And now we know it is a multidimensional and multi-organ dysfunction syndrome with multiple pathophysiological mechanisms. How to go about next? Whenever you come across a frail person elderly frail person with CKD for your advice, the first step is that please resort to the help of your geriatric physician's help. The first step is the holistic, wholesome geriatric assessment with a special relevance to cognition, mobility, mood, and nutrition. After that is over, take note of all that. And then the role of the nephrologist as a second step is that assess the frailty. There are any number of instruments. As per the literature, more than 70 tools of assessment for frailty are there. They are broadly classified into two. One is the physical performance-based instruments, then the cumulative functional deficits-based instruments. I'm just quoting the two examples for the physical performance-based. It's called the Fried phenotype. Fried is the name of a person, which is considered as the gold standard. But thing is that there are 5 phenomena. If 2 are there, it's called pre-frail. If 3 out of 5 are there, it's called frailty. But it's a bit time-consuming, and it requires certain special tools like dynamometer. But another criticism of that is that it does not test the cognitive and the emotional, psychological aspects and so on. And next to it is a short physical performance battery test. It is adored by many investigators. It's easy to perform. But again, the hand grip strength is not tested in this also, but for practical clinical purposes, the short physical performance battery test is better. And the next set of tools, the frailty assessment instruments, which assess the cumulative deficits. There are the big list is there. The clinical frailty scale is very popular. Each one of them have got multiple domains and their scoring mechanism is there. With all these, you can diagnose and then grade the severity of frailty. And you may ask one question, are they comparable? Yes, this is one nice paper, they say. The Edmonton Frailty Scale, Frailty Index, Frailty Phenotype, and Clinical Frailty, they are comparable. And similarly, another set, also it is comparable. Because if you want to do any research, like you have to understand, if each investigator has adopted different instrument, how to compare them. Fine. Then what are the implications? Let me move on to the implications. So far, I've spoken only about the physical frailty, but the physical frailty is invariably accompanied by the psychological frailty and the emotional frailty. These two components are not included in the definition, right? So all these domains of frailty are there present together in a given patient. So the consequences are acceleration of CKD progression, the need for early initiation of dialysis. Many times, an inexperienced consultant can think the manifestations of frailty as uremia, and you just as a knee-jerk reaction, you initiate dialysis early, that may prove adversely. So then impaired adherence to medications by the patient, vulnerability for infections because of immunosenescence, the frequent falls with all the complications and fractures, increased rate of hospitalizations, the cognitive impairment, impaired nutrition, physical dependence on the caregivers, increasing cardiovascular events, and overall quality of life being impaired. And more importantly, increased healthcare expenditure. So it is not just a problem for the individual and family, but for the entire system as well. And the most important is enhanced mortality risk. The more the frailty, the more the chances for mortality. This is a nice paper which assesses the prevalence of physical frailty and impact on survival in patients with CKD. It's a meta-analysis. As per this paper, the prevalence of frailty is about 35% in CKD patients, and pre-frailty is about 40%. Okay? And the frailty is lesser in the pre-dialysis CKD, still lesser in transplant recipients, but it's more when the patient reaches dialysis dependence. And the mortality risk increases by 94%. So screening for frailty and intervention are of utmost importance in all stages of CKD, which is very often ignored in our routine practice. And again, frailty should be included in CKD prognostic scoring. Yeah, this is the algorithmic stepwise approach. Understand whether there is frailty. If it is there, assess the severity, and then list out all the problems, and then chalk out a management plan individualized to that patient involving all the stakeholders. Don't take a decision on your own. Moving on to dialysis. When a frail elderly person is in need of dialysis, okay, according to one meta-analysis, home-based dialysis is better with improved survival and lesser hospitalizations, better symptom relief and treatment satisfaction, and inconvenience of travel to center is avoided. But the flip side is that with all the difficulties when the patient reaches the hospital, at least he gets a chance to socialize with others and opportunity to talk to others and so on. That is very, very important as far as the quality of life is important. And again, shared decision making. Because whenever you decide to initiate dialysis for a frail elderly person, as I've already said, you don't take a decision on your own. There should be a very holistic discussion with the patient and caregivers, and we have to be very honest in explaining the prognosis, and we should be very honest in accepting there are many gray areas where the outcome may not be good, and so on. And the implications, the cost implications, and the caregiver burden that is going to increase, all these have to be discussed threadbare, and then you have to take a question. This is a paper from our colleagues from Manipal Hospital in Karnataka. How do they go about? In a patient who's reached end-stage kidney failure, whether to go for dialysis or only conservative kidney management. This is how they go ahead. There is something called surprise question. What is the surprise question? Meaning, you ask a question to yourself. Will you be surprised if this patient is still alive after 12 months from today? If the question is, I will not be surprised, he may not live longer. So that is an important factor to determine. And complete assessment of the physiological and the physical variables, and then the patient choice with all these shared decision making, and if all the stakeholders believe that dialysis is unlikely to improve quality of life or longevity, don't go for dialysis, only go for conservative kidney management. And again, there are a lot of challenges in dialyzing the patients with frailty, because the rate of vascular access maturation is slower, higher rate of vascular thrombosis, need for more frequent vascular access revision and intervention, and in peritoneal dialysis, increased chances for peritonitis. And after initiation of hemodialysis in a frail person, initial phases will be very turbulent. There can be a sudden decline in the physical function in the early stages of dialysis. And the chances for intradialytic hypotension results in silent stroke and white matter disease that can worsen the cognitive impairment, and the phenomenon of myocardial stunning is more common. Peritoneal dialysis has certain advantages in certain aspects, but the frail person cannot handle the heavy dialysis bags, definitely. The dependence on the caregiver increases, so the caregiver burden also increases. Okay, which is the best mode of dialysis for a frail elderly person? As per the available literature, you can't be very certain that one particular mode of dialysis is superior to another. But one thing is very sure, the purpose of dialysis for an elderly frail person is not just satisfying the fixed targets and so on. It is not just for prolonging longevity, but more importantly for alleviation of symptoms and facilitating social activities, chances for travel, socializing, meeting people. That is more important. Keep that in mind. So no fixed target, no excessive ultrafiltration, no aggressive dialysis, incremental dialysis whenever it is possible, and so on. That is more important. Okay, how about kidney transplant? A frail patients, obviously, the chances for getting them for a transplant is much less, and while awaiting a transplant, the mortality is high. Particularly frailty with the history of serious falls, the getting chances for listing for transplant itself is very less. And those who get a transplant, a frail patient, how do they behave? First 1 month, frailty worsens. Next month, it reaches the baseline level. From 3rd month onwards, there will be improvement in the frailty. And please remember, frailty is not an absolute contraindication for kidney transplant. You have to individualize your decision. What is required is a multidisciplinary and multimodal management, and taking into account all the factors which we have mentioned. The most important is the nutritional rehabilitation and physical exercise. These are the two things. And never miss out. And when assessment of frailty, suddenly there can be an impact of acute events, acute medical events, which may worsen frailty. Don't get befooled by that. So don't miss out on acute infection. In a country like India, there can be a hidden tuberculosis that can be contributing to that. You have to identify. And chronic asymptomatic hyponatremia, hypomagnesemia, atrial fibrillation, dysglycemia, hypothyroidism, adrenal insufficiency, all these will be contributing to frailty. Please identify these are the remedial component of a frailty. No, this is mandatory, fine. Then the two pillars of management is, I've already said, nutrition supplementation and exercise training. And you all know how much importance of protein and calories, B-complex vitamins. There are programs of intradialytic, oral and parenteral supplements as well. And exercise, the most important thing, very often we ignore, aerobic exercise, resistance training, simple walking, static cycling, and yoga, a lot of importance for yoga now. So this is one trial, Excite trial, a home-based, low-intensity walking program for 6 months. The cohort who received this 6 months low-intensity home-based training, there is tremendous improvement in all components of the phenomena, bone health, cognition, hospitalization rate, longevity, and all that. That is why KDIGO says that at least 150 minutes per week of moderate intensity physical activity is mandatory. And again, a similar guideline from the peritoneal dialysis society. Again, they have given the modes of kind of finish. The exercise that is advocated in CAPD patients as well, very simple cycling and body weighted resistance exercise and so on. But never forget, it is not just nutrition rehabilitation, physical exercise, also psychological and emotional support and cognitive training. Very important. Avoid polypharmacy, get into de-prescribing, that itself contributes for frailty. And final word, a patient is on dialysis, in a frail person, there may be chances that we may have to withdraw the patient from dialysis as well. In serious other comorbidities, and the chances for longevity, chances for continuous sustenance of life is very meager, and it adds on to a lot of physical and mental agony for the family and the patient. Don't hesitate to withdraw. Again, it should be a shared decision making. And final word, in the current nephrology practice, particularly a country like India, you are a kind of a multitasking nephrologist, you know, starting from OPD services, clinical nephrology, dialysis, transplant, research, intervention, everything. In that, multiple demands of a nephrologist in a low resource setting, the component of taking care of the patients on maintenance dialysis is unfortunately coming down. Please never do that. You have to pay enough time, focus, attention, energy on taking care of the maintenance dialysis patients. An elderly person, you just say hello to him, hold his hand for a moment, that itself will bring in a lot of positivity in the patient. With this humble request, I thank the organizers for giving this opportunity. Thank you so much.
We have got, I believe, 17 minutes, I mean, in fact, 13 minutes. So if I get all the three speakers on the stage, please stay. So if there are any questions, you have got 13 minutes to ask. And obviously, you can always ask questions after the conference at the end of the session. So please have a seat. So please, if there are no questions, then we chairperson will ask the question. And that is not fair. So is there anyone who would like to ask a question to these three lovely speakers who have come all over from other countries? They are all yours. So if there are no questions, my first question to you would be that when we talk, and this is, I think, a common practice, that when we hear that there are 850 million people in the world living with CKD, and I think that's a very good message for politicians, etc. But for a clinician, the prevalence of stage 4 and stage 5 chronic kidney disease is 0.5% of that. So it comes to around about 40 million. I did calculate that in India at the moment, possibly you have got 5 million people with the stage 4 and stage 5 chronic kidney disease. And if I was to be even more specific, you will have 1 million people in India today with stage 5 chronic kidney disease. Do you think that by changing the policy matrix and going to the politician or policymakers, that we will need 1 million people to go on dialysis or transplant or renal replacement therapy? And do we have the workforce, we have got the resources, I think that will focus the mind more, because what is happening at the moment in developing world, that the whole message gets swallowed by 850 million people, or we give them 10% of the population, is the politicians just shy away. They say the workload is so much that it won't happen in my lifetime. A politician life is 5 years. They're not thinking of 25 years. 5 years, I have to win the election again. So my plea to all the people who are in the developing world, to please just give them a target that I want 1 million people to be requiring dialysis or whatever. I think that would be then also help the policy maker to come and help you, that how to deliver that workload, how to get there. Do you think this is going to be a good strategy?
Yeah, it's going to be a difficult strategy, keeping in mind the amount of the infrastructure required, the manpower required, and the amount of the funding required. So basically, it all depends upon the way you convince the politician. Politician, you also take, not the challenges, but the solutions. So when you approach as a scientific person, so I think they definitely listen to you, but you should go with the, the solution, not the challenges. So again, it should be like a staged approach, not just you just target and then say this much is required. And you should give us the split targets. And of course, you should able to, as you said, it should be a multidisciplinary. And of course, you should be able to tell them, because ultimately they see that what is going to help the population by and large. And of course, to be frank, they also look at the vote bank. The next time, what is the politician would help them in getting this the vote bank. So we should be able to convince. That's the strategy you should use, the politician, and making them aware, making them cognizant of the load, and of course give them the proper strategy. In fact, in our own state, it has gradually evolved over a period of a decade. So we had two governments back, holding the government for two terms. So we could convince the government, and we could slowly, we have started the, spoken in my talk, the hub and spoke model. So we have shared resources from the, involving the scientific community, involving the public, involving the government, and involving the private agencies. So we have put everybody as a stakeholders and taken it forward slowly. So I think it's a strategic approach we should be able to convince them.
This,
yes, the thing is that for the past couple of decades, particularly for the past 1.5 decades, the governmental policies and principles are very, very heartening. Even though we are nowhere near the target, the pace at which the kidney care is improving, at least in some states of India. Again, I cannot say the same thing applies for the entire country. India by itself is a subcontinent, it's not a country. Particularly the state where I am coming from, like Tamil Nadu and Dr. Swarnalatha, Telangana, the progress in kidney care is tremendous, because I've been in the field for 30 plus years. The death due to the proclamation of the diagnosis of CKD was a death sentence when I was a trainee in nephrology. Now, our Prime Minister has proclaimed that nowhere in India, any corner, nobody should die for want of dialysis, and that is happening. It has become a reality. How? Strengthening the public healthcare delivery system. That's more important. India, again, the healthcare delivery system is very heterogeneous. On the one end of the spectrum is the hi-fi corporate sector. On the other hand, it's a kind of a very, very cost-effective public-run hospitals. I have been working for the government for 3 decades, very cost-effective. And there are so many dedicated professionals and paramedicals, and if everybody can join hand, that would be very good. But even for 1 million, it is very difficult. So more and more focus is for prevention. Now, Tamil Nadu government goes, it's not just primary, secondary, tertiary prevention. There is something called primordial prevention for chronic kidney disease, meaning addressing the maternity health care. If you are able to achieve the average birth weight of the population, you may bring down the incidence of CKD later on. Brenner's nephron endowment concept. Now, over the past couple of decades, tremendous enhancement of the maternity health care, and though MMR and IMR, everything is reduced and birth weight is increasing. The prevention starts from there, and then screening the target populations, targeting certain risk populations for dipstick proteinuria detection. Already 3 million people in Tamil Nadu have undergone that. And then early detection of hypertension, diabetes. Any adult who reaches any public health care delivery system, from a village primary healthcare center up to the tertiary health center. Irrespective of the clinical problem for which he or she resorts to the health, BP will be checked, sugar will be checked. So early diagnosis of asymptomatic hypertensives and diabetics is happening. Then the problem of non-adherence and not taking tablets. Now what we have done is that delivery of antihypertensives and anti-diabetics at the doorstep. It's called Tamil Makkalai Thedi Marthuvam. Government machinery delivers antihypertensives and anti-diabetics at doorsteps. In addition to that, because of our persistent insistence, even CAPD bags are also delivered at home for patients to improve this thing. So this is, and then establishment of dialysis centers in every district headquarters, taluk headquarters hospital, in a very, very cost-effective way. The public health insurance scheme, even with zero balance in the personal bank account, a person can have a successful kidney transplant with a lifelong immunosuppression free of cost. Immunosuppressives are procured at a central level at a very, very, very minimal price. And it is lifelong, it is given free of cost. Starting from primordial prevention up to the tertiary. And again, even though number of nephrologists is increasing, it is not enough to provide the conservative kidney care management. So we have developed modules of how to take care of early stages of CKD and be imparting that information to the primary and secondary care physicians, virtual meetings and physical meetings and modules and guidelines and so on. So there are multiple fronts of government's role. So the government machinery is so powerful and we have to do a lot of researching, how to minimize the cost, and in a cost-effective way we have to. The most important challenge is that we have expanded the services, but the quality assessment, still it is lacking. That will be the next step. Maybe the next decade, that is it.
Thank you. Mathu, you have a question?
My question is the first speaker. Thank you very much for your spoke. I noted that your cost per dialysis is 1,750 rupees, and it's the same as Professor Magdi said for the Bangladeshi, but we had almost a double. It's cost about 6,000 rupees here, it's costing about 11,000 rupees. How were you able to get that low, the cost of a dialysis?
No, basically it was all calculated based on the consumables used, and it's cost per the service. So the private party, government only provides the place in the community health center, and the electricity always provided by the government. The machine, the consumables, the technicians, the nursing staff, everything is provided by the private party. And the amount 1,700 goes to by the insurance to the party. Right. So we have calculated that in Indian rupee it has come to, and that is profitable. In fact, we have calculated the cost comes around 1,200 Indian rupees.
The contract is for 1, 2 years or 7 years, 10 years? What is your contract?
Its contract is lifelong. We have a monthly package. So monthly package 10 dialysis is 17,500. So it's like lifelong, as long as patient is living.
Who runs that dialysis center?
It is under the control of the government, but the third party runs it. And the insurance company, it's a public insurance company, pays to the third party. We are the nephrologists, we go and check the quality. We monitor the patient. We look at because it's a third party insurance based. So we try to select the patients who will go to the dialysis. We check their parameters. We do the pre-authorizations. We do pre-authorizations. These are the patient fit to undergo dialysis in the particular center. And once the dialysis is done, we do a monthly review basing on the patient parameters and look at whether dialysis is adequate or not, and we approve. Once we approve that, only then the payment is made to that party. So it's a shared responsibility. Scientific person, we look at the patient care, clinical care, and then the quality check. The government provides the hospital platform, the community health center. It is a third party which is giving the service of having a dialysis machine, having the technicians, having the nursing staff, and doing the service part at that particular time. So we have telemedicine monitoring on daily basis. We have this, all the data coming onto our dashboard. We have this, the hospital informatics, every information is coming to our dashboard. And we do physical, the visit also once in a while, because these are peripheral centers which are 100 kilometers, 200 kilometers away. In rotation, we go there once in a month and we do a physical, visit also. And after this physical visit, we have to actually give the quality check, and we have a checklist. We have to upload all these things. This center is following all the standards. Once we do that, only then that party will be getting it's something like money, issuing the money after you do a quality check. So this is a complete quality control, and things happening for the past, I believe, 15 years now, and it has over a period of time it has evolved, and I think we are also looking at the initially, as sir said, probably it's the numbers, but now we are looking at the quality check as well.